Good evening. Welcome to the 26th Annual Alamo Advocate Program and our flagship event, Hot Topics. I'm Beth Emery, and before the program starts, I just have a couple of words about Dr. Susan Love, who died July 2nd, 2023, after a long struggle with recurrent leukemia. Susan was one of the foremost breast surgeons in the country, but she also led in the field of clinical care, research, and advocacy. She was an early and dedicated mentor on our Hot Topics sessions and a true advocate for patients. Knowing that ending breast cancer requires advocate voices in action, she was part of a small group of women who came together in 1991 to form the National Breast Cancer Coalition. Through the strength of her charisma, brilliance, and firm belief in women's power, she helped unite activists, survivors, researchers, policymakers, and grassroots and national organizations to work together towards ending this disease for good. Susan was an innovator, a leader, a compassionate doctor, an author, and a researcher. She didn't set out to be a breast surgeon, but when no job offers came after she ended as chief surgical resident at Harvard, yeah, welcome to the world, she hung out her shingle, and the patients who came to her wanted breast surgery. She wrote the Breast Book, which is our Bible for breast cancer, and that's really something both men and women rely upon when they're diagnosed with a degree. Importantly, she was one of the first outspoken skeptics of hormone replacement therapy, and her position was very controversial at the time, but she was ultimately proven right. She started the Army of Women, which is a website that creates a database for clinical trial accrual for both healthy women, healthy patients, as well as men and women who have had breast cancer. And she led the NBCC advocates on the dance floor every year at our annual summit until we quit hiring the DJ. And I frankly remember her leading the conga line. She was great. NBCC simply would not exist if it were not for Dr. Susan Love. Her loss is felt deeply, and the breast cancer and advocacy communities will always miss her, but always think that she was with us for a while. Thanks.
I had the opportunity myself to actually get in touch with Dr. Love and collaborate with her before. I'm Dr. Sanford James, and I want to welcome everyone to the Friday evening session of our Hot Topics. This is the final session for the week, of course, and what an exciting week that we've had thus far here in San Antonio. We're very fortunate this evening, of course, that we have an esteemed group of mentors who will be highlighting some of the things that they have learned not only yesterday, but through the week, where they will provide highlights of all the things that they felt like was worth sharing. Before we begin anything, we have to, of course, thank all of our sponsors. Programs such as the Alamo Advocate Program would not be possible without the support of our sponsors. And I do want to thank Exact Sciences, Genentech, Merck, Novartis, Daiichi Sankyo, GE Healthcare, Seagen, Minari Stemline, Eli Lilly, Pfizer, Issei, Vitarus, Joe W. and Dorothy Brown Foundation, and the Carpenter Foundation. Let's give a round of applause for our sponsors. And of course, programs such as the Alamo Advocate Program would not be possible without the stream and vast amount of volunteers that provide their time, those individuals that provide their expertise, more importantly, providing their structure so that we can have an effective advocate program here in San Antonio. As I mentioned earlier, I do want to remind everyone that our mentors are here to answer your questions. There will be a question answer at the end. The format that we normally utilize is for our mentors to share what they have seen this week, share some of the highlights and overviews of some of the research that they found. I do want to remind us also, please silence your phones. As you know, programs such as this are going to be live streamed. Any distractions, of course, distract us, but more importantly, it may also be a distraction for our speakers and even for the audience who may be asking questions. With that being said, I do want to introduce our mentors for tonight. We have Dr. Steffi Oosterreich from, again, she's representing the University of Pittsburgh. We have Dr. Keith Knudsen, of course, from the Mayo Clinic, and Dr. Jennifer Richer from the University of Colorado. And I want to begin this evening, of course, with Dr. Oosterreich, who I had the opportunity to be on the panel with on last year, believe it or not. Can you tell us some of the highlights or things that you found to be interesting this year?
Yes, absolutely. So at first, I want to just start with saying hello to everyone. It's great to see such a big crowd here. I realized there's quite some competition going on because there's the, what are you doing different in the trenches next week, right, at the moment. So I think I appreciate you guys being here. So again, I'm a translational breast cancer researcher. So I'm not a physician, I'm a PhD, but I do enjoy very much multidisciplinary research with physicians and also working with breast cancer advocates, and some of you are in the room here. One more little piece of information. Last year when I was here, when I started to talk about, I said, this is the hot mentor session instead of the hot topic session. I thought, it's still true, so I thought. Anyway.
That is in hot fashion.
So yeah, so I thought, as every year, I think San Antonio meeting is absolutely, absolutely fantastic. So many new things in basic translational and clinical research. And I want to start with mentioning two stories which were shared today, which I think are very close to my research interest. The first is on invasive lobular breast cancer, and the second on endocrine resistance. So maybe I can expand on this a little bit, yeah? So the lobular ILC presentation was from Dr. Fraser Pereira from Memorial Sloan Kettering. And she presented on using an AI, an artificial intelligence algorithm to improve diagnosis of the disease. And maybe to backpedal a bit, the diagnosis of the disease is clearly limited by challenges. I think there are a couple of papers which are published over the last few years really showing stark discordance when the pathologists look at the slides, what the pathologists call invasive lobular breast cancer, mixed cancer, which has both ductal and lobular features, or a ductal, now also called NST, no special subtype. And I think we clearly need to improve that, especially these days where clinical trials are ongoing specifically for patients with invasive lobular breast cancer. So what Fraser presented, what she and her team did, was taking as the ground truth genetic inactivation of E-cadherin. E-cadherin is a protein that sits on the surface of the cells. It makes the cells attach to each other. And the hallmark of lobular breast cancer is that E-cadherin is lost. So they basically went out there and say, okay, I'm going to train the algorithm on tumors where I know the E-cadherin gene is mutated. And they took many hundreds and thousands of tumors. Actually, I shouldn't say this. I don't remember exactly the number, but many, a lot of large data, and trained, and the computer basically picks up specific features from these tumors with mutant E-cadherin. And then they do it on many samples. It's a very complex algorithm, but then in the end, the computer is able to take other tumors now and say, okay, is this a lobular breast cancer or not? And they showed that the sensitivity and the specificity of this algorithm is really high. 80, 90%. And the few which were EKTRN wild type, but the computer picked it up as a lobular breast cancer, it actually turned out that indeed it was a lobular breast cancer. It just wasn't defined by mutation in EKTRN, at least not classical mutation in EKTRN, but by other ways of inactivating this gene. So not only did we improve, well, I didn't do this, did the speaker improve the capability of diagnosis of the histological subtype, but through that methodology, they also identified novel biology underlying the disease, because they then looked at these tumors, which the AI algorithm picked up as lobular, but it is EKTRN wild type. We then looked, oh, what else happens in these tumors, yeah? So it also really sparks more biology, more mechanistic understanding of drivers of the disease. So I think that's only the beginning of research of AI. We really can expect a lot more, but I think that example for improving, standardizing diagnosis, I thought was a really, really good example, especially for lobular breast cancer, where we now have clinical trials actively accruing patients to really standardize diagnostics of the disease, yeah? So that was fantastic. That was in the general session this morning. And the other talk I want to mention, which was also in the general session, was from a young MSTP, who I'm actually, I should say, super proud to say. He was a student in our lab in Pittsburgh. He's now in Boston, and he is working on endocrine resistance. And I think, and we might come back to this later, a major mechanism of resistance to hormonal therapy are point mutations in the estrogen receptor. So basically, the DNA gets messed up. You have just one nucleotide which changes, and it makes the receptor active in the absence of estrogen. So if a patient takes aromatase inhibitors, you get rid of all estrogen. The receptor usually can't function, so you block tumor growth. You hopefully block metastasis and progression. But very often, in the presence of these mutations, at some point or another, even if you give additional therapy, the tumor gains resistance again to that additional therapy. So for example, now SERDs have been shown to function, to have efficacy for these hotspot ER mutant tumors, elacestrant, great example. And unfortunately, some of these tumors, after a time, develop resistance again. And what Nolan has shown in the presentation today in his work, and this is a large teamwork again, is that the next mechanism of resistance is that you basically just break the gene in half, and the gene fuses to another gene. It's what we call a fusion. In other diseases, it's very well described, like some of you might have heard about the Philadelphia chromosome and others. In breast cancer, that has not been described that well. But he showed that you basically cut off the end of the estrogen receptor, you fuse it in a rather promiscuous way to other genes in the genome, and somehow we think this might be the ultimate mechanism of resistance, because the piece you break off is the ligand binding domain. I mean, even if you take estrogen away, if you have other drugs which potentially could bind the receptor, they can't bind any longer. Not only that, the new partner, when you break the gene in half, you have half left, and you get another partner. In some cases, that partner makes the gene super active. So you have this what we call gain of function. So you not only have activity from the estrogen receptor, you even get maybe another kinase now going crazy, yeah? So these fusions, at the moment, the idea is, maybe 4%, 5% of endocrine-resistant advanced metastatic breast cancer have these fusions. They might even be higher just because a lot of sequencing technologies don't pick them up. So now there is clearly, we can find them, we can characterize them in the lab. Obviously, the next step is how do we treat these tumors, right? And that is active research ongoing. Two obvious questions are, is there a specific pathway turned on downstream of these fusions, which we can target? Or the other is that the estrogen receptor, maybe what we call the N-terminal, the beginning of the receptor, maybe you can find something to target that part of the receptor, which has been a challenge for drug development. But I think now, with having the incentive that we think there might be a growing number of these ER fusions in endocrine-resistant metastatic breast cancer, maybe there's, again, incentive for the drug companies to really work on that, yeah? So those two stories I want to share because I think they have a lot of promise for additional progress in treatment of patients, yeah?
Thank you very much, Dr. Usserreich. That's an amazing overview. Dr. Knudsen, can you tell us some of the things that you found to be, captured your attention?
Yes, thank you. And I brought a cheat sheet, so bear with me. But anybody who knows me knows that all roads lead to vaccines. And so, basically there hasn't been a lot of vaccine research that was presented, but there's a lot of vaccine research that's going on in a variety of different cancers, including breast cancer. It's an area that I've been at the Mayo Clinic involved with since 2005. And in fact, in my early part of my career as a postdoctoral fellow at the University of Washington, I became very interested in developing vaccines, and this was back in the late 1990s, with colleagues at the University of Washington because I had family members that were affected by breast cancer, so I had the opportunity of moving into a laboratory and really start to learn about immunology and try to build a career at, not only basic discoveries, but also applying that in populations. And as a PhD scientist, I've been pretty successful at doing that. I'm currently the principal investigator of 7 clinical trials testing vaccines from a very early stage, phase 1, all the way up into phase 2. And so the hope is that we will see some action in the next few years with respect to improving survival in individuals with breast cancer, and I also work quite a bit in ovarian cancer as well. The work that we do spans all the way from the treatment of bulky malignancy, identifying vaccine strategies that can shrink tumors, and preventing recurrence in individuals that are at high risk. And certainly that's where there's a big need for individuals with breast cancer after, standard of care therapy, surgery, chemotherapy, and radiation, doing something to boost the immune system so that it can seek out and, protect against cancer recurrence. And even more recently, with the National Breast Cancer Coalition, have been, and many of you know this, we've, over the last 10 years or so, started to develop a prevention vaccine for the primary prevention of breast cancer, which we have gone through many different think tanks to try to put that together, and that's advancing as we speak now. Very advanced, in fact. It's moved to the National Cancer Institute, where it's been licensed by the National Cancer Institute. We have various manufacturers, big name manufacturers, that are helping us develop this vaccine in order to eventually test, hopefully within the next year, starting to test it, the ability to generate strong immune responses to multiple antigens that we typically find on breast cancer, and then ultimately move that into a prevention setting to try to prevent breast cancer from even happening in the first place, all forms of breast cancer. So that's where I come from, and so I'm going to talk just briefly about some work that was talked about today, and it's unrelated to vaccine, but I'm going to take it to vaccines because that's what I know how
All
to
roads
do.
lead to vaccines. All roads
And
lead to
so,
vaccines.
of course, there's many studies that have been published and many of you are familiar with the concept of tumor infiltrating lymphocytes, right? And so there's been work that has been done over the past 20 years or even 30 years looking at the infiltration of tumors by various immune cells. And most of those have focused on immune effectors that are associated with the adaptive immune response. So that's the immune response that responds to, infectious disease vaccine, that generates that memory that protects you against an infection. And it's the same for breast cancer, it's the same for other cancers as well. Focusing on those cells because those are anti-tumor cells, and looking at the relationship to the prognosis or response to therapy in individuals. And if it helps them survive longer, longer disease-free period, hopefully saving many years for you in terms of overall survival as well. So there's a number of those. I'm just going to talk about one. There was a study that was done with atezolizumab monotherapy. So this is an area that we've worked on for probably 10 years before anti-PD-1 or anti-PD-L1 was very popular, because many of you, probably don't know that anti-PD-L1 was actually discovered at the Mayo Clinic back in 1999. And so I had the opportunity of working in that area, particularly looking at the efficacy in combination with vaccines, because that's what I do. And so this particular study was done by Hans Christian Kohlberg from Germany. And it was looking at atezolizumab, which is not, actually it's not approved for use in triple-negative breast cancer here in the U.S. and I don't believe Europe anymore, but there's still a number of phase 2 and probably phase 3 clinical trials that are ongoing, testing this to see if there is the potential for its use in breast cancer. Certainly in other cancers, it is approved for use, like non-small cell lung cancer, and I think various cancers of the urogenital tract as well. And so this was a study that was done, again, by Dr. Kohlberg. It was a phase 2 study, and they were asking the question whether or not if you give before immunotherapy of triple-negative breast cancer is often combined with, here in the U.S. it's combined with chemotherapies combined with pembrolizumab in the neoadjuvant setting in individuals with triple-negative breast cancer, resectable triple-negative breast cancer. And so, and it's used similarly, atezo is used similarly with chemotherapy. And what they wanted to determine whether or not if you gave atezo prior to chemotherapy, would you get a better effect than mixing the two? So there's a timing issue they're trying to work out, because there's a lot of problems with the potential use of chemotherapies and immune-based therapies because we don't know a lot about the interactions. In some cases, chemotherapies can block the generation of an immune response. In some cases, they can block the activity of T cells or B cells in your tumor. But each chemotherapy is different, and they all don't behave the same. For a long time, we thought they were suppressing the immune system, but it turns out that they're not suppressing the immune system, but they can impact the generation of an immune response. So what they found, they thought that they went in with the hypothesis that if you pre-treated with atezo, then continued with atezo and added on the chemotherapy, that it would improve the pathologic complete response rate. So what we want to achieve, of course, with neoadjuvant therapy is we want to achieve pathologic complete response, complete disappearance of the tumor at the time of surgery, because that's associated with long-term survival, right? Unfortunately, they didn't see any difference in the PCR rates between those that started atezo early versus those that got chemo and atezo at the same time. But what they did find is that individuals that had PD-L1 positive tumors, which is a marker of immune activation, had a 90% PCR rate. So that's only a fraction of patients, unfortunately. And compared that to the control group, which was 80%. So there is some signal there that perhaps priming the immune system a little bit better prior to giving chemotherapy may improve immune checkpoint blockade therapy. So I thought that was very, very interesting. But PCR doesn't always mean improved survival. There's been other studies done, for example, in melanoma that have looked at pathologic complete response to neoadjuvant therapy, and it had no impact on overall survival. So certainly longer-term studies are needed to follow up on whether or not that slight enhancement, but nonetheless important enhancement of PCR by atezo given early in the course of neoadjuvant therapy is important. But one of the interesting things that they also observed is that the PCR rates that they observed with atezo were even better than Pembro. So the question is, is this something that we may see in the future, despite the fact that the registration for license to sell at FDA and European authorities was removed? I think it was last year or the year before, if I'm not mistaken. But really, the overall picture that painted for me and really confirmed something that I had been thinking is that in order to respond to anti-PD-1 based therapies or anti-PD-L1 based therapies like Pembro and Nivo and atezo, durvalumab, you need to have a pre-existent immune response. And so that's extremely important. And PD-L1 elevated in the tumor as a marker for response to those kinds of therapies indicates that you have a pre-existing immune response. How do you get a pre-existing immune response? Vaccines, right? So, so you see where I'm going. Now I'm going to go on to the second one. So that just kind of supported this idea that that I'd been thinking about since way back in 2010, that only a fraction of individuals are going to respond to immune checkpoint blockade because those are the ones that have the immune response. And so that was very interesting. Now, people are starting to look at ways at generating immune responses prior to neoadjuvant therapy in individuals besides vaccines. But I'm going to come to the vaccines, but I want to talk about a study that was done by Angel Arenat, presented by Angel Arenat and her colleagues from Ontario, Canada at Ottawa Hospital. And this was intratumoral dosing of early stage breast cancer patients with INT 230. And INT 230 is essentially a formulation of vinblastine and cisplatin along with a diffusion enhancer. So we don't typically think of those as immune modulators, but given very locally, you of course eliminate the systemic effects of those agents, and they have a lot of systemic effects. They've been used in breast cancer at the systemic level in the past. And so they formulated those for intratumoral injections because data had shown that both of those agents actually activate the immune system, right? So here we have the scenario again. We want to improve the response to immune checkpoint blockade, to Pembro, to atezo, to Nivo. How do we do that? We can give them this immune modulator and stimulate inflammation in the tumor, and then once that's stimulated, then the presumption is that they have that immunity. And then that's what atezo is going to act on. That's what pembro is going to act on. That's what nivo is going to act on. And indeed, this was a small trial. It was a randomized phase 2 trial, but it was relatively small, and they weren't looking at like overall survival or recurrence-free survival. It was just kind of a window of opportunity study to ask the question, does it generate an immune response in the tumor microenvironment? And so indeed, it did. They found evidence of increased gene expression of various immune effectors. So the question becomes now, is that something that you can give to improve responsiveness in individuals? Because PCR rates are probably only around 60% when considering the combination of paclitaxel and pembrolizumab, and probably around 60% when considering the combination of atezo plus chemotherapy as well. So there's an opportunity now onto thinking about the generation of an adaptive immune response with vaccines, and that's something that piqued my interest in a study that was in one of the sessions today entitled Germline-Mediated Immune Editing Sculpts Breast Cancer Subtypes and Metastatic Proclivity. And what that means is that genes that are normally expressed in your body, when they become upregulated, they generate immune responses, and those immune responses kind of dictate which direction the tumor goes. Immunoediting. So if you have a tumor and it has upregulation of HER2/neu, and you generate an immune response of HER2/neu, and it wipes out all the cells that express HER2/neu, but the tumor is still growing, then it's a HER2/neu negative cell. So that's what immunoediting is, right? So your immune system sees one tumor and kills that, but essentially the tumor starts to grow off without expressing HER2/neu. And so this was an interesting study where they used TCGA and very advanced bioinformatics. And I took a look at, there's a pre-publication online, very exciting data. Something that we had been hypothesizing as immunologists for the past 20 to 30 years, but now we have the tools. We have these fantastic new bioinformaticians that are being trained that can go through, tons of data. I mean, the amount of data that we have with sequencing and multi-parametric strategies, multi-omics, is just absolutely incredible. What they found is that, basically the more epitopes are what T cells recognize, okay? The more epitopes that the tumor has in it, the better the protection from advancement of the disease. And in the example that they used, they found that individuals that had a high epitope, they called it a high epitope burden, but it's really not a burden. You want all those epitopes so your immune system can attack the tumor. But a high epitope burden was associated with a lower reduced risk of transitioning from DCIS to invasive breast cancer. And one of the interesting things is they defined epitopes based on just normal proteins like HER2/neu, MUC, some of the things that, P53 that we often hear about. And they determined what looked to me like a T-cell mediated immune response is being generated very early in the course of disease development. I'm not talking about DCIS, I'm talking about before DCIS. So immune responses are developing very early in the course of the development of breast cancer and perhaps other cancers as well, because your immune system, as I think about it, is largely trying to keep everything in a state of normalcy, right? And so when it sees something unusual, it's going to generate an immune response. So I thought that was very interesting and really has a lot of implications for what we've been working on with the National Breast Cancer Coalition and the other advocates over the years, and that's the development of a prevention vaccine for breast cancer. Because what that is telling us is that we need to target these antigens like HER2/neu that are expressed very highly, maybe early in the course of disease development. But what's important is that we need to target many of them. And so the new, advocate-driven vaccine program, Artemis, that we have targets 6 antigens. And all of these are very common antigens that develop in breast cancers. And so this new study that was based on bioinformatics and patient follow-up across the spectrum of cancers, breast cancers, tells us that we're moving in the right direction by trying to stimulate high levels of immunity in individuals. I'm not even going to say patients. I have to train myself not to say patients, because we're going to eventually get to the point where it's going to be individuals that are at risk for developing breast cancer and hopefully prevent it at some point in the future. So thank you.
Dr. Nussin, thank you so much. There's a lot of exciting things happening, and now we're going to hear from Jennifer.
Hi, I'm Dr. Ricker. I'm at the University of Colorado. And like Steffi Osterreich and I have a lot of similarities in our background and our training, and focus on hormone receptors and endocrine therapy resistance. We've published some papers on the ESR1 mutations together. And I have to say, my disclosure is that I was busy working on my talk today on the translational research year in review. So I only went to 2 talks today, I have to admit, 2 sessions. And one was on the ESR1 mutant biology, but it was right before, and I had to run down to my session. But I just think it's so exciting how many options we're going to have with these new selective estrogen receptor degraders, and just determining the timing and the sequence and which ones work best is going to be really challenging but interesting. And then the other talk that I wanted to just briefly mention, because I actually heard the whole thing, but you probably all heard it as well, Dr. Alano Wilms' talk on her after winning her AACR award. And I wanted to say how I was thinking when she was speaking that, the take rate of breast cancer is being engrafted into the mice, and the way it determined the rate of rapid progression in patients. I think that the way she's now developing the patient-derived organoids, where she can screen different drugs rapidly and see which person individually might respond to the different drugs in the screen in time to potentially inform the clinical trial or the clinical treatment, is really a great advancement, because when we put them into mice, and by the time you can expand them and have enough mice in each group, it's just not practical. And so the patient-derived organoids are super useful. But it also made me think about how the triple negatives, it's much easier to make those patient-derived xenografts from triple-negative breast cancer, whereas ER-positive disease doesn't usually progress as rapidly, but the eventual likelihood of recurrence as metastatic disease is unacceptable, right? And nobody wants to be taken by surprise 15 years later when their disease recurs. So there have, between Alana and Mike Lewis and Carol Sartorius, who's an investigator in my department in pathology at the University of Colorado, we have a few more of these patient-derived xenografts and organoids that are from patients with ER-positive disease. Of course, the most aggressive ones are those that acquire this estrogen receptor mutation that makes the estrogen receptor able to act and turn on a bunch of other genes even without the estrogen around. So, but again, these selective estrogen receptor modulators and degraders will help with that. But when I was giving my talk today and learning more about how these antibody drug conjugates work, I was thinking, you know, I bet that in the future, quite soon, we will have a lot more choices of which antigens to go after. And the trophoblast protein, the top two, you know, it made me think of some research that we've done in my lab where the most aggressive, both ER positives that are highly aggressive and triple negative breast cancers can start to express antigens that only these earliest cells of the embryo, the trophoblasts, make. And the reason that is quite interesting. It's because in pregnancy, the earliest stages of the embryo, they actually make immunosuppressive factors that can dampen the maternal immune response. And the reason that's actually a good thing in pregnancy because it keeps the maternal immune system from going after the early embryo and it prevents against miscarriage, basically. And so it's a good thing in pregnancy, but when tumor cells actually de-differentiate and harken back to this embryonic state, they can start making these trophoblasts-like antigens and the immune suppressive factors that the early cells of the fetus make. And in cancer, it's not a good thing to suppress the immune system. We want to boost the immune system and have it go after these cancer cells, which of course is difficult because they're our own cells just gone wild. But they do often have mutations, as we know. But if the ones that are becoming really aggressive start to make these trophoblast-like antigens, and there's a lot of them, then I think we can really take advantage of that and maybe start making more antibody drug conjugates with antibodies to these immune suppressive antigens that are very trophoblast-like, because none of the adult cells should be making those things, so they might be quite effective. And Steffi, I'm going to ask you to jump in and discuss ESR1 mutations with me because I didn't get to go to a lot today, and I thought the only thing we could talk about today were talks that occurred today. But since I was giving mine, I didn't attend a lot. I did Nellie Polyak's talk yesterday. It was quite interesting on the diversity of the T cell heterogeneity, and that sort of decreasing as we age. I thought that was quite interesting and affecting the progression of DCIS. But I think I'll stop there and open it up for discussion.
Let's give our speakers a round of applause, please. I think we have a number of topics that we can actually probably have questions about. I do want to remind us, if you do have a question for the speakers, there are microphones that are here in the aisles. Please state your name, your institution or organization that you represent. Try to remember this is not a platform for diagnoses. Try to make sure that your questions are related to not just some of the discussions, but we want to avoid personal references and questions as we try to question our speakers. I think one of the things that I saw a prevailing, strong type of platform through everything that our speakers have talked about is the actually amazing advancements that we've had. We talked about vaccines, we talked about receptors, immunotherapies, but now we're talking about a combination of things that can really, I think, change the outcomes. We do have a question here in the audience.
Hi, I'm Beth Emery. I'm with the Alamo Breast Cancer Foundation and the National Breast Cancer Coalition. And I have a question about a general session topic this morning. Dr. I'm going to mess up his name, Horto Bagye, did a report from MD Anderson, did a report on the Natalie 3 trial, and he gave further information on the final endpoint data. And this is a trial that was dealing with the use of ribociclib along with aromatase inhibitors in early breast cancer, not metastatic breast cancer. And unfortunately, I think the questions are not put into the tape so that you can see it later, but one of the first questions was, okay, we're going to treat early breast cancer patients with a CDK4 inhibitor, which has a lot of toxicity issues, physical toxicity issues. It has huge financial toxicity issues because this was an attempt to have them go for 3 years on AI and ribociclib for a relatively small number of patients that we prove can benefit. Does this make sense? And the doctor said, cost-benefit analysis is above my pay grade. I was like frank about that, but I found it very troublesome that we have a trial where everybody's very excited about ribociclib and we're going to add it, but we're doing these trials that create a very small benefit for not that many patients, but have a lot of side effects, including, importantly, economic consequences. What are your thoughts about that, and your thoughts about what should we be doing so that principal investigators consider financial toxicity to be in their pay grade?
Yeah, I think that's a great question. Actually, I just realized, I think we had a fourth person on the panel, which was a physician who I guess couldn't make it, yeah?
He could not make it.
So we have, I think, just full clarity. Are you a PhD as well?
Well,
So we have 3 PhDs here, just in full clarity that the 3 of us are not physicians, but I think we can try to address the question, yeah? I thought it was a great question from the audience. I think people do think more and more about this, both about financial toxicity as well as about toxicities, health toxicities for the patients, and I want to come back to that. For those trials, I think and that affects us as researchers, is that we need to clearly figure out which patient will benefit from it and which do not. I think that's why when you have these biomarker-driven trials, where you already know, okay, only patients which have a PI3 kinase mutation or an ER mutation go into this trial, then I think it's much more hypothesis-based. Here, everybody is treated. And then, it takes research to figure out what's a biomarker to predict who should go on the treatment and who not. And there was in the same session, I think it was in the same session, there was another presentation from a similar trial. It wasn't ribo, but it was Abima. It's a different CDK4/6 inhibitor, where the team, I think it was presented by Nick Turner from London, where they are now basically they're going back to the sample from the trials, to the tumor samples, thanks to the patients who actually agree to donate then the sample to be able to look at the sample. And they sequence it, and they looked, okay, which gene predicts which patient responds and whatnot. And he stressed that it's preliminary, it's exploratory, but it looked like in that trial, when the tumor overexpressed MYC, which is a well-known oncogene, maybe the patients don't respond that well to Abima. Again, exploratory needs to be repeated. But I think that's what we need, right? That's why we do the research. I think we now need to go back, get samples, and really understand better who responds, who doesn't. So I think it was a good question, yeah.
Yeah, I can chime in as well. I think Steffi's completely right that the prediction of who will respond in a window of opportunity, a short duration of treatment, maybe just weeks, and then take samples and then do the molecular analyses to find predictors of response. Because especially when you're dealing with a drug or this class of drugs that does have a lot of toxicity, And you have a lot of options with the endocrine therapy, which, you know, has side effects, but not much more tolerable. Well, I shouldn't say that, but comparatively. I think that it is good to not proceed with a trial where everybody will be treated, but to do a short-term neoadjuvant window of opportunity and look for biomarkers through research. And Steffi's exactly right.
Thanks.
Maybe I can just quickly expand on one thing. We didn't mention this earlier, but one of the talks was one of those late-breaking abstracts where you realize it's important enough that the organizing committee from San Antonio slots it in at the end. And there was a presentation about a trial where it was focused already on a specific subpopulation on patients with PI3 kinase mutant breast cancer. It was presented by Dr. Kumar Javeri, and the trial was the Inavo 120, where there's a new drug targeting mutant PI3 kinase. I think it was super exciting. The hazard ratio is like 0.4, which means the progression-free survival is like more than doubled. And that is one of those trials where toxicity is going to be a real big discussion. I think they already showed that toxicities were there. Clearly, with these PI3 kinase inhibitors, you have hyperglycemia because they affect metabolism. And the study population in that trial was, for example, if I remember this correctly, was like 38% Asian. And the entire trial was one black woman. And glucose level, entry-level glucose, is really important if you have a drug which affects metabolism, PI3 kinase. So this is one of those trials which was super, super exciting, super promising. But again, you need to do more to have a more representative population in such trial. And then I think also, to think about what are the toxicity, what acceptable and what not, yeah. But I'm sure we'll hear more about this, and I just thought it was, super, super exciting drug, and hopefully I'm sure we'll hear more about that.
We can leave it up to the advocates to bring up a topic that's really needed to be talked about, and financial toxicity, of course, is one of the topics, and I want to thank you for bringing up the fact that we do need to have more diversity as we go into the research as well. Dr. Knudsen, did you want to add any comments around the financial toxicity?
Well, my two PhD colleagues did a fine job. So, I mean, the same things can be said for, immune-based therapies as well. We have plenty of, agents like immune checkpoint blockade, some of them which have some real, drastic side effects, and some which are permanent. So, for example, one of the patients that I'm currently vaccinating was on a combination of ipilimumab and pembrolizumab, and developed adrenal insufficiency that, something that this individual is going to carry around for their life, and they're going to have supplementation to deal with low levels of corticosteroids in their blood. And so, this is a real concern. It's the way we've done things in the past, but there's increasing efforts and interest in developing biomarkers that can, help. And I think with, AI technologies coming about and new technologies to, look at, what are the characteristics and phenotypes of cells that would, benefit from a certain medication over another one are going to be very important, because unless you have that, financial toxicity is going to be a horrendous problem for many of the newer drugs that become available, because they're just so darn expensive. You think about CAR T-cell therapy or Pembro, you're talking, $15,000 a month or $150,000 a year for, CAR T-cell therapy, for example. So we need those, and I think that, the tools that we have are going to really revolutionize how we think about applying these new medicines by, identifying and adopting and figuring out ways to adopt biomarkers, which has been a problem too.
Thank you very much. We do have another question here from the audience.
Thank you. My name is Naomi John. I'm from the Inflammatory Breast Cancer Network in the UK. Something that you just said really piqued my interest. So the inflammatory breast cancer is often seen in younger women, often nursing mothers. And in your speech you said the immune cell suppression in pregnancy that happens naturally to protect the fetus. And I'm just wondering whether there's any activity that is in progress anywhere to look at inflammatory breast cancer, because we know that this occurs often just after pregnancy.
Mm-hmm. Yeah, my colleague, Dr. Ginger Borges, that spoke one of the nights earlier, I don't know if she talked about that. I didn't get to come that night, but she and Tracy Lyons work on these immune suppressive factors that are made during, continued through pregnancy into the involution stage, where the cells, after they stop making milk and the child weans, you still have a lot of immune suppression going on there. So you have inflammation, but you also have these factors that dampen the immune system, because they actually want to tell the immune system this is, because there's a lot of remodeling going on and a lot of cell death when you have involution after the lactation. So the immune system these things are made to cool its jets so that it knows that this is a physiological process, not an infection. But that remodeling combined with the immune suppression may be what permits this postpartum breast cancer to be so rapidly metastasizing. So it's definitely a really active area of investigation, and actually Carol Bess back there is helping us with a grant that we have on this very topic as a patient advocate. So.
Thank you. I'm really encouraged to hear that, so thank you for your efforts. It's a really aggressive subset of the disease, and the patient profiles, it's just tragic that we lose so many nursing mothers. It's horrific. Thank you.
Can I comment on this? Just one
Of
comment.
course.
There was actually a poster here at the meeting yesterday on inflammatory breast cancer. It was a really large study, maybe one of the largest, where they sequenced it. And they compared the genomics of it and looked for mutation which might be different to non-inflammatory. And somewhat surprising, there was only one gene which was different, which was TP53, P53 gene. So suggesting that there must be stuff in the microenvironment, right? It's not the genomics of the tumor cells, but something else. That's why the idea of maybe the immune environment, maybe it happens during pregnancy or whatever, but it's clearly not the genomics in the cancer cells.
Yeah, we think these things that are made in the cancer cells that are similar to what the trophoblasts are making, the regulation is through transcription, so it's not mutation related.
Yeah.
It's sort of hearkening back to a transcriptional program that should only be turned on early in development by the trophoblast, but the cancer cells, through this sort of de-differentiation process, they can use normal things that should be shut down in adult cells, but use that program, and then they don't have to reinvent the wheel. They can start opening up regions of chromatin and having transcription and translation of things that should not be made any longer in adult cells.
We have a research program that the IBC network in the UK is funding through Birmingham University, and they're specifically looking at the tumour microenvironment. And we've managed to cobble together funding to keep that going for the next 6 months, and we're looking in a good shape to keep it going beyond that as well.
It's great.
Thank you very much for your comments. Next question, please.
Hello, my name is Julia Levine, and I'm a metastatic patient advocate and the lead research advocate for the Lobular Breast Cancer Alliance. And my question is for my favorite hot mentor, Dr. Steffi
There we go.
Osterreich. I was in both of the sessions that you talked about, and they were both quite complex, so I want to see if I can get to them a little bit more in lay terms for myself and everybody in the room. My sense from Dr. Pareja's talk on AI and locating CDH1 mutations or lack of ecadherin in in non-ILCs that were later discovered to be ILC from AI. And is that correct?
That's correct.
And then, is it mostly primary? She didn't mention whether there are primary tumors or metastatic tumors. I'm not sure if it makes a difference.
I think almost all of those were primary tumors.
I think so too. So, my comment about that is perhaps with AI, we would get to more than 10 to 15% of lobular breast cancer. Perhaps there are way more that we don't know about.
Yeah, I don't think so. I don't think the number will increase significantly because the number of false positive and negatives they had there were pretty small. They were pretty small. So I don't know, maybe you get 2 or 3% more. And at the moment, as you know, it's already always people say a range, right? Oh, it might be 8 to 13% or 10 to 16%. So it won't go much higher than that, yeah.
Okay. And the second one was about the, with Nolan Priedket's lecture. That was a little over my head. However, I think when you're talking about fusions, there are RNA fusions as opposed to DNA?
So they happen at the DNA level. So DNA pieces break and then fuse. And that happens very often in the genome, but most of them, the moment it gets transcribed to RNA, what's the next level, right? DNA, RNA, protein. The moment it goes to RNA, the majority of them get degraded. The cell picks it up, there's something wrong, get rid of it. But some of them at the RNA level, they are stable. And then some of those, which are stable, we think are actually oncogenic driver. They actually cause resistance, cause tumorigenesis, and ER fusions, we think, are some of those. So it happens at the DNA level, gets into the RNA, and then some of those, like the ER fusions, make a protein which looks totally different.
And so, for instance, I had an RNA test with the MSK impact study that was a failure. So, but normally those aren't tested in genomic testing. It's just in trials, correct?
So the majority of those tests do not pick up the fusions.
It's just not
That's what
tested.
Nolan's point. He said he had 9 fusions there, and 8 of those 9 had genomic tests, and none of those 8 tests picked up the fusion. It's only if you then do deeper next generation sequencing, you find them. So that's the problem.
And the one that he was talking about was the ESR1 fusion only,
Yes.
right?
The estrogen receptor fusion.
Right.
Yes, that's correct.
Okay.
Yes.
Thank you. I hope that.
Yes, no, that makes perfect sense. Absolutely. Yeah.
Thanks.
Hello, thank you for being here. My name is Sarah. I am a metastatic breast cancer patient, someone living with metastatic breast cancer. And I have a question about cohort studies, cohort subgroup analysis. And I'm curious about how you are thinking, what do you think about when you approach presentations of these cohort subgroup analysis? What are their limitations? What questions do you ask? And I'm thinking about this in terms of 2 things, the poster spotlight session on endocrine resistance this morning, where the cohort subgroup analysis were presented from the Emerald trial and from the Capitello trial. And they were both presented in a way sort of framed as across these different subgroups, we see improvement from standard of care, so we can feel really good across these subgroups that it's going to work. But it was also really noticeable that the subgroups really varied, so that in the Emerald study, the HER2 low was 9 months PFS, whereas the PIK3CA was 5.45 months. And the same with the Capitello, there were differences, and I don't know if we should think about those as significant. But also in terms of the way it's playing out in FDA approvals with the limitation of electrons to ESR1 mutations. I'm probably pronouncing these drug names wrong. And also the kind of conversation about length of response to CDK. It seems like cohort subgroup analysis are really in play in conversations, and I would love to hear more about how you're thinking about interpreting those.
Anyone who wants to start?
Well, I mean, when I design clinical trials myself, you have to be powered for subgroup analysis. And so it's one thing when you go back and, do a retrospective analysis of one of the studies that I quoted earlier was a subgroup analysis from a phase 1 clinical trial or an early phase 2 clinical trial, and that was the therapy with atezolizumab. And they did a subgroup analysis on an uncontrolled study, an uncontrolled subgroup, and it turned out in phase 2 it wasn't true because you need to really, tightly control the variables that you're measuring at any point in a phase 2 or phase 3 clinical trial and how it connects to clinical benefit, whatever that clinical benefit is. And if you don't, for reasons that always aren't clear, you can get a false positive reading on a specific variable that may not hold up in a controlled clinical trial. But nonetheless, those kinds of subgroup analyses, if you don't have the data, are very important for advancing the field because they, give you information that, could be potentially useful for developing new biomarkers or new strategies.
Mm-hmm. Yeah, I totally agree. And, lobular breast cancer is a really good example that very often the trials are done, it's 10 to 15% of the overall breast cancer population. The trials are not powered that we can actually look at lobular breast cancer. Nevertheless, I think people now, and advocates in the room like Julia and Giovanna, they now go back to the investigators or the pharma company and ask them, can we actually look, can we break out, can we do a cohort retrospective analysis? But it's never powered enough to really, you cannot show that this is actually, but you can get an idea and maybe it gives you a hint what you want to do in your next study.
Evidence for a bigger trial,
Yeah.
Thank you.
Hi there, I'm Ann Fonfa from the Annie Appleseed Project. So I have heard of the trophoblastic theory, and I want to say that in 1902, the trophoblastic theory of cancer was published in The Lancet by John Beard, who was a Scottish embryologist. All these years, it's been considered alternative and a world that I partially dwell in. And so now it's coming to the fore. Why I always defend the world of alternative, because sometimes it becomes mainstream. Very happy to hear it.
The theory has been around for a long time. I think particularly now with so much more interest in the immune system again, it's interesting how these things go in waves. But I think, just today I was thinking we need to use more of these types of antigens because they're not expressed in the adult cells. So with the antibody drug conjugates, we could really take advantage of that. And then a lot of the things are also don't require contact between two cells. They're secreted immune suppressive factors. Like there's one called chitinase like 3. There's the SIMA7A that Dr. Ginger Borges and Tracy Lyons work on. There's an enzyme called IDO and TDO2 that are involved in tryptophan catabolism. And that was originally discovered in trophoblast cells and the placenta, making this to suppress the immune system. and it actually expands T regulatory cells and it expands MDSCs, and it inhibits the viability of the cytotoxic T cells. So, and now they're making more drugs. The original drugs that targeted IDO only, and this other enzyme that evolved separately to also do this tryptophan catabolism, that drug, the first drugs in clinical trials didn't hit it, and it can compensate for the other one. So, you know, all of this is tricky, but now there's some drugs coming out that hit both of these. So bottom line, I think, you know, research is the key to this, and you know, exploiting these things that are affecting the immune system and keeping it from effectively going after the cancer cells is going to be really important.
We have another question from the audience.
Yes, my name is Kira Gustafson, and I'm a patient advocate with LBCA. So my question is relative to vaccines. I know you're dying to talk more about vaccines. And it is in relation to, this isn't a conversation about COVID, but what we learned about the COVID vaccine with the mRNA is the possibility of lymph node inflammation. And so my concern with the future vaccines is that going to be an issue? Because sometimes it was said that you can't have a mammogram 6 months after the COVID vaccine, or somewhere, I don't know exactly if it was 6 months, but I know it really did on some people inflame lymph nodes. So just today, it was mentioned about cells getting inflamed, lymph nodes getting inflamed, and I wonder, relative to the future vaccine, where are we at? Or do you have anything to add?
So first off, I can't see you because I've got these like two
blinding.
giant orbs of light in my, so I'm trying to look in that direction, but I may not make eye contact with you. So the lymph nodes themselves are part of the immune system. They're an essential part of the immune system, and they're composed of B cells and T cells and dendritic cells. And that's where your immune response is actually generated. So as a vaccinologist, that's what I want to see, is I want to see evidence of the activation of the immune system in the lymph nodes, because that just means that it's doing something. Now, what we don't want to see is we don't want to see it going on for 6 months.
Yeah, and I wonder, how does that relate, though, to breast cancer? So that's more my, are we,
So there's a couple of different things. Number one, you could have, immune factors that are draining into the lymph node and causing it to become inflamed, as you had mentioned, or activated. And so that's a possibility, but also breast cancer is known to grow in lymph nodes by mechanisms that we have no idea why. You would think that this is the home station or central depot of the immune system, and yet cancer cells can grow in the lymph nodes.
Yeah.
And so there's a big challenge there. So, and one of the reasons may be that, and we think, is because breast cancer and other cancers, as I already mentioned, are highly immune suppressive. So when they go in there, they can shut down the lymph node, in terms of its activation, and they can grow, and that can cause lymphadenopathy, that can cause, swollen lymph nodes. But there's also the other side of it, which is immune activation. That can result in, essentially closing off what happens during a vaccine is the vaccine component drains into the lymph node, and actually the vessels around the lymph node that allow the cells to escape from the lymph node clamp down. And the idea is that what you want to do is activate those cells that are responding to the antigen. But you also want the antigen to disappear after some point in time. If not, you'll develop tolerance to whatever that antigen is. And that's been demonstrated in other vaccine trials, where if you have persistence of antigen, you also have increased tolerance or reduced responsiveness of the immune system to whatever that antigen is, whether it's the flu or polio or something like that.
Okay, well, thank you.
You're welcome.
What a very rich discussion that we've had this evening. And I'm mindful that we do have evaluation forms that are on your table. Please take time to complete the evaluation forms. I'm also mindful, again, that we want to thank all of the individuals and people who are responsible for our program this evening. And yes, we do have additional questions as well. I just want to make sure that because we are being live streamed, we do have to be mindful of the people that are following the live stream broadcast. And we do have time to ask additional questions of all of our panelists following our program this evening. So they will be around to answer any additional questions following the program this evening. I do want to take time again to acknowledge all of the sponsors. Without our sponsors, we would not be able to put forth a program such as this. This is Friday, and of course, this is the last of the hot topics. Our sponsors this evening, of course, are Exact Sciences, Genentech, Merck, Novartis, Daiichi, GE Healthcare, Minari Groups, Stemline, Segan, Eli Lilly, Pfizer, ISA, Vitaris, the Joe W. Dorothy Brown Foundation, and the Carpenter Foundation as well. I do want to remind everyone, please take time to perhaps visit our hot topics for next year in December of 2024. And I thank you again for joining us this evening. Have a good night.